master's and PhD programs in clinical ethics at the University of Montreal. For her training, she did her bachelor's in biology at the McGill University, and then received her medical degree from the University of Montreal, and then did pediatric and neonatology training at the Royal College of Physicians and Surgeons of Canada, and a PhD in biomedical sciences from the University of Montreal. I find it fascinating. She's a pioneer in patient involvement and research. She's an international speaker who has given over 200 presentations, and some of her greatest presentations when she does them with parents, which is kind of one of her niches, is getting parent involvement. She has been invited all over the world, Australia, New Zealand, USA, France, Belgium, UK, Argentina. But more personally for us, she's also the parent of 3 children who have had or have healthcare needs, one of them which was born at 24 weeks. So both professionally and personally, she is an expert in the things she talks about. So without further ado, welcome Dr. Janvier to speak to us today.
So you could all sit forward, you know. It's kind of weird. There's like a back line at the back. So thank you for inviting me here. Today I'll speak about parent and family important outcomes after extremely preterm birth. Who here is in medicine and has done some neonatology? Most people. Okay, so I didn't speak about neonatology too much at depth because I thought I would be speaking to doctors. So I study ethics. In ethics, there's not much money. So when you don't have money, you don't have disclosures. So I don't have disclosures. But I have no conflicts, but I'm conflicted. As Mark said, this is Violette. This is my second baby. All my kids had different kind of problems, still need the healthcare system episodically. So this was her when she was born at 24 weeks. So sometimes I'm biased about this, and I was on the other side, and I'm still on the other side of being a patient or the mom of a patient or the daughter of a patient. So I'm not very lucky in health. So usually I give this with a parent, this presentation. So she speaks about her story and I speak about the scientific stuff. So, but today I'll be the parent. So I'll tell you when I become biased and I put my parent hat. So today we'll speak about limitations when we measure outcome measures, like for example in neonatology, that parents have different ideas about what matters, and that's important to integrate stakeholder or family important outcomes in research. So, you know that 10% of babies are born preterm, about 10%. It's like 7 in Canada, it's about 9 here, it depends of the decades. And 1% are born before 29 weeks. This is your charming president that I find very cute. But the importance is not that he's cute as a president, but that he had a preterm baby, for those who don't know, who was born at 35 weeks. And his Patrick Bouvier-Kennedy died from RDS. And that's not that long ago. And President Kennedy helped actually speak about neonatology, make it more public, and have financial incentives to do something about it. So it kind of sparked the interest in North America in neonatology. And survival rate now has increased dramatically. I mean, you don't die of RDS at 35 weeks anymore. It's something that, you know, we could see extremely rarely, but it's not something we see. But we still measure outcomes in neonatology. Many fragile babies survive for those who round in neonatology, but mortality is still significant and morbidity is significant. So we measure neonatal outcomes in the field. So we collect data like ROP, BPD, oxygen need at 36 weeks, and NEC. And we have neonatal follow-up. In fact, neonatology invented the field. You don't have PICU follow-up, oncology follow-up, respiratory follow-up, but we have neonatal follow-up to know how the babies are doing later on, either for clinical reasons, that if there's something we can do, that we screen and we can improve outcomes, or for quality improvement. Are we worse than last year, better than last year? Are we comparable to other units, worse or better? And research, if we do something, does it impact cerebral palsy later on or other outcomes? And to inform parents, so prenatally to tell them this is what happens to a baby when he's born at X and prepare for X. So this is follow-up in Canada, but in the US, you're organized differently, but in a similar fashion. So all babies of less than 29 weeks are followed up and they have a standardized examination. And at around 18 to 21 months, they have a follow-up visit where hearing, vision is evaluated, physical exam is done to see if there's absence or not of cerebral palsy, and the Bayley-3 is done, and this gives a score. So these children are all evaluated in the CN Fund in Canada. All the units are together and pool their results together for QI. And this enables clinician and researchers to classify kids. So kids can be classified according to neurodevelopmental impairment as having no neurodevelopmental impairment, so no problem, having mild or moderate neurodevelopmental impairment, so having some cerebral palsy and some developmental delay, or severe neurodevelopmental impairment. So what I learned during my training with policy statements, either from the AP or the CPS, is that doctors should communicate all possible outcomes and risk and alternative to parents in a standardized and neutral fashion. So decision aids came out at that point about 20 years ago. And the information transfer was seen as the most important thing. And I think, unfortunately, it's still the way it's done, and especially in the US, where you have to transfer all the data of all the potential problems that could happen and what you can do. And I believe that at that point, and I made a parent information sheet for parents who could deliver preterm. And this is the way we're taught in medicine to see life, with those kind of graphs. This is a good graph in a good article, so I'm not picking the article. So you have the percentage of neonates and you have the gestational age. And as you can see, you have less bad outcome or babies that have adverse outcomes as you go up in gestational age. And we're made to believe that red are bad outcomes and green are okay outcomes. So we're meant to believe to sometimes reorient intensive care, because a baby is better off dead than to have the red outcome, or to not give intensive care at birth because we want to avoid the red outcome. So measured outcomes influence life and death decisions. You'll go in the AP statement or the CPS, Canadian Pediatric Society statement, or if you look at your decision aid, survival, the NICHD, survival without profound neurodevelopmental impairment. They don't say survival. And then of those who survive, how many are impaired? So judgments about what is futile and beneficial are made using these statistics, without any input from families who are given these outcomes during prenatal consultation. So I remember a follow-up physician, neonatal follow-up physician, who said, I've seen this kid, and I don't want to write serious disability, severe neurodevelopmental impairment, because he's really happy and he's doing actually super well. So his outcome is good. He's loved, he loves people, he goes to school, he's got friends, he's functional. And I'm like, well, this is the way it is. This is how neonatologists view the world. So this is severe. And she's like, well, I don't think it's severe. And his parents don't think it's severe, and he doesn't either. So this is where this collaboration was born for the Voice of Parents that you'll hear. So now I'll put my parent hat. I warned those of you who arrived after the beginning that usually a parent gives this story with me, but I was also a parent of a 24-week baby. So now I'll speak as a parent. So now I'll be biased, okay, and I'll use swear words. And then I'll become a scientific person again. So this is me, like beached whale with sexy glasses. 20 years ago, at 23 weeks gestation, at that point, a third of babies survived. I showed up in the delivery room, contracting, bleeding, cervix open again. And I was told that, this was all happening because of my incompetent cervix. So even the words we use in medicine, even the person whose term has a failure to progress, there's a lot of failing language in obstetrics. So incompetent cervix, like imagine you're rounding and a baby's malformed and you tell the dad, he's like this because of your incompetent sperm. That wouldn't work at all. But we say that to women all the time. Oh, you've got incompetent cervix, you may deliver prematurely. So this was me, and I'm married to a neonatologist who's evidence-based medicine guru, Keith Barrington. So we knew the numbers. We'd written the papers. I wrote my stupid parent information sheet that was given to me that was worth nothing at that point. So information transfer was not enough to take decisions. We knew all the numbers. We were working with those patients. So when my good friend Sophie, who was a neonatologist who came to give the prenatal consult for those who'd written the papers about outcomes, came to see us and said, well, what do you want to do? Hold her while she dies, intervene, do something. Actually, we didn't know what to do. All that knowledge didn't help us. So statistics are not enough to take decisions. And this is true for all your patients. And I fear that often what we do is give them more information about outcomes. And this doesn't necessarily help parents make decisions about life and death, and make them decisions about home antibiotics versus hospital antibiotics, but those are not the same thing. And now with our research, and you'll see the results, parents have other kind of questions. And I had those kind of questions. Questions about my baby, like, can she be happy later on if she's disabled? Will she have a good quality of life? Will she be able to have friends and function in the world? And about me, can I be this mom, this super mom that I see in the hospital of a disabled child or a child who dies? And what about my career? And what about my family? What is the impact of prematurity on couples and on my son and on the whole of the family in general? We don't have data about this. So this was Violette, her first few days. And I knew her body composition, her vent settings, but I had no idea how to be the mom of that little blob. I was very lost. And I hadn't been shown this despite PhDs and 18 years of university. So she wasn't breathing enough because her dad's an apnea specialist. So she had 3 intubations. And for those who are in neonatology, the number of intubation is never measured as an important outcome. So it's not measured. So if you have a trial about lung outcomes, there's only BPD that's measured, oxygen at 36 weeks, but the number of intubation a baby has is never in the database. I can't find one paper out of the hundreds of papers that counts the number of intubation. It'll be important. This is why it's there. They also gave my daughter's name is Violette, and she was too desaturated too often. So the nurses changed her name and they've called her Violette Rose. And they put pink stuff around because they wanted her to saturate better. So this is at one of those intubations. Then she nearly died. She had her 4th intubation from a septic shock. It was, she didn't pee for 3 days. It was pretty gruesome. For those who want to read my book, it's described in there. And then we had a lot of ups, and then she had a pleural effusion from a PICC line, so her 5th intubation, and then more ups and downs. And then she had ROP stage 3, other intubation, and then you know neonatology, so that's how it goes. But she went from this is Keith's wedding ring that he sent to the laundry. I think now we're at wedding ring number 3. Around her wrist. This was the nicest one, but I bought cheaper one as it went because I know they won't last very long. So this is the wedding ring around Violette's wrist. And when she left, this is what it looked like how much she'd grown. It's amazing what we do, right? In neonatology, a patient can be 4 times their weight. Thankfully, we don't do that in adult medicine. So according to neonatologists, Violette had a good outcome, not a bad outcome, because she didn't bleed in her brain. She still had 2 sepsis episodes and a small neck and ROP that's severe. And people were very happy because she had no BPD. At 35 weeks and 5 days, she came off oxygen, but she still had so much steroids, so that kind of possibly explained it. But nowhere in her discharge summary is it written the number of reintubations, urgent or not. So then we were told that it was time for the term MRI to see how Violette's brain was. And Keith and I are, we have enough data, thank you, too much information. And the term MRI is special because there's nothing really you can do with the results. You can do research with the results. So we would have had the term MRI for research and hide the results from us. But this was really clinically for positive predictive value of CP. So the negative predictive value is pretty good. The positive is pretty shitty. It's like 50%. So we didn't think we could deal with more merde. That's shit in French. And we just wanted to get out of the hospital and not try something else. And that we had enough information. So this is Violette around a year and a half, a year. So the Bailey is, so Violette would go to neonatal follow-up and she would have her exam. So we're, very performing clinicians. We're going to prepare her for the exam. So this is her preparing. There was Bailey boot camps every day. So she'd had to put her little Cheerios from one pot to the other. She had to, we kind of prepped her for the Bailey because we were like, she's going to have a good mark. And so that's not an unfair advantage for those who know the Bailey that can prepare their kids. So when she went to follow-up, it's really hard follow-up for those who do it or look at that. You feel they're judging your baby and they're going to put a mark on your baby. And it's kind of reflecting a little bit you as a parent. But so the kind psychologist came to see me, and after this thing of naming things and going through this and going upstairs, and she says, "Oh, I'm glad to tell you that your child is normal." I'm like, "My child is normal? Like, she's fucking amazing. Like, what is this? Like, she's gone through all that stuff. And this is what she does, and she's normal." I'm like, nah, she's not normal. She had like 103. I'm like, please. But the thing is, they were measuring things, but not the things that were a problem for Violette, because she had serious problems. Like, she had stridor all the time. She needed dexamethasone every time she had a tiny rhume. What you have when your nose cold, yes, froid, yeah. She had feeding problems, aversion and not being able to eat properly and choking and sleeping problems. So we all had sleeping problems and real important executive dysfunction that in school they're not told to manage properly because it's not really the executive dysfunction that we have in typical kids with executive dysfunction. Not much research on that. So these are not serious problems for neonatologists. In fact, they're not measured. So any BPD research doesn't measure ENT outcomes. The feeding outcomes are not measured very much. Sleeping and executive dysfunction, some rare studies. So when you don't measure something, it's not important. If you don't have data, you don't have trials. And if you don't have trials and data, you don't have resources. You can't have the tag or the etiquette to merit the resources as a family. So her severe ENT problems became very bad when she was 13. Because the trachea that with the intubation becomes a bit calcified is good for a 5, 6, 7-year-old. But then when you have a growth spurt, it's unable to grow. And then you have to breathe through a tiny straw. And for the ENT colleagues, we see that all the time. We have about 1 a month that we do this surgery, a reconstructive tracheal surgery. She might need a trach, she might need this might happen. But I'm like, nobody knows this. And like, I'm a neonatologist, I'm an academic. I go to the BPD meetings. Nobody's ever spoken to me about this. He's like, oh, come on. Like, this is very frequent. If you go to ENT conference, they speak about it. If you go to adult cohorts of preterm, a lot of them have a hoarse voice. They speak about it. A lot of them have a scar here because they had tracheal reconstruction. So this is like shocking that these can be outcomes that we don't know anything about in neonatology and breathing experts don't know about. So this is her now. She's a nursing student and we've kept her super active and she does Spartan races with us. This is her on the monkey bars. She does them way better than me. And I force her to do runs with me because of her new trachea. She doesn't have a choice anymore. Before she's like, oh, too difficult. I'm like, yeah, now you can do it. So then this is the in-between talk where I'm preparing to be a doctor again. But I've read a lot of books then to try to see this kind of side that we're not taught in medicine. This is a very good book from Andrew Solomon, who's a PhD in psychology, Far from the Tree. There's one chapter per condition, and there's all children with different disabilities. He calls them exceptional children. And he interviews parents of, for example, achondroplasia, where the house is reorganized with everything lower down, where it's easier to be parents that are small with a small child than parents that are very tall with a small child, or a very small parent with a very tall child that can beat them up. And there's every chapter like that speaks about autism, about Down syndrome, about all kinds of conditions. And it was really nice to have the voice of parents in there. And there were no parents of preterm kids in there. And what I got from that book is that a lot of things that are measured in medicine are not important to families. And a lot of what's important is not being measured. And thankfully, so this is when I become a boring doctor again, a researcher, we put together the Parents' Voice project of let's go get the information from parents of what they find important and how can we co-create definitions of neurodevelopmental impairment, or what is a disability, or what is a problem. So there's parents in there, Kate and Rebecca. There's Paige an amazing, the US has stolen them from us. She's now in Harvard. She lives with spina bifida. She's amazing. She's a neurodevelopmental person who does neonatology. And Sinis was the chief of Canadian Neonatal Follow-Up Network. Lindsay was a researcher, and that's me. Mai is my colleague who didn't want to call the kid severely disabled on the picture I showed you. She takes care of the CN Fund now. Claude Julie is a sociologist of science, of how we evolve and how we actually describe disabilities. And Magdalena Jaworski is in rehab medicine. And these are for those who want the publications. I'll summarize them in the next few slides. You can write me an email and I'll send you the papers if you want them. So our first question is that when in neonatology, we categorize children as severely disabled, mild, moderate, and no disability, do parents actually agree with those classifications? So they don't. So for a whole year, throughout Canada and all the neonatal follow-up clinics, we told parents, look, we're going to categorize your kid. This is why we do it. We do it for QI. We do it to see if we can do anything. We do it to have some information. But we've never asked parents to categorize their children. So according to you, is your child functioning well, or no disability, or mild to moderate disability, or severe disability? And parents, they tend to be more positive. So this is what you'll see in the publication. So there was 1,084 parents, children were evaluated. And when you look at the CN Fund classification, so the way doctors classify patients, 54% had no disability. When you ask parents, a little more. So 83% of parents agreed. This is still a problem. It means 1 in 6 parents think their kid is disabled when the doctor says everything's fine. 1 in 6 is still problematic. So this is probably what we would have said if we would have been asked for Viola, because her function wasn't very good despite the 103 at the Bailey. When kids were classified as having mild or moderate neurodevelopmental impairment, 40% of parents agreed. They thought their child had no impairment, most of them. And when they were classified as having severe neurodevelopmental impairment, only 12% of parents agreed. Most of them thought they were mild or moderately impaired, and many of them thought they weren't impaired. So this is one of the big problems, is that when we speak to families about, oh, your kid will be severely impaired, most of the parents would not agree with that. Like, this is not the definition of families. Then we wondered what we have decided as doctors and researcher that is severe. Is it actually severe for parents? The answer here is no, in general, not. They tend to be more positive. So how did we do this? We did this with vignettes. So you invent stories. And this is a very good way to do this. If you want people to put a value in a health state, but you don't want to ask about a particular patient because we feel bad putting a value in a patient's life. But if you put it on a hypothetical story, it's easier. So we created stories of kids who had disabilities, and we distributed them to parents of very preterm children to preterm children that were older. And this is an example of Jamie. They were all like unisex prénom names, so that people weren't influenced that this was like a fragile girl or strong boy or whatever. So Jamie's an 18-month-old child. He can sit with support and rolling creep on his stomach. He has stiff legs and will very likely use a wheelchair for longer distances. And so he has cerebral palsy. He has, as we describe as doctors, severe cerebral palsy. The rest is described normally. He can hear, he can learn, he can follow simple directions, he can speak. So we asked for all of those health states. There were 12 health states. There was a child who was deaf, a child who was blind, a child who had mental impairment. So if 0 is the worst possible health, 10 is the best possible health, where do you think Jamie fits from 0 to 10? And does Jamie's case describe a severe healthcare condition? I won't go through all the vignettes because it's going to take forever, but you can see that Jamie, cerebral palsy, that his health evaluation was 7 on 10, so it's not perfect from parents' point of view, and there was 827 participants. And the percentage reporting the condition was severe was 43%, which is interesting. And so you can see here that hearing impairment for parents and families and kids is 8 out of 10, and 17% think it's severe. But visual impairment is worse, 6 out of 10, and 51% think it's a severe health impairment. So if you look at the percentage of respondents rating vignettes as severe healthcare conditions, the maximum down there, this is cerebral palsy, it's Jamie's case, 43%, but the maximum is 55%, like barely like the majority, who think that cerebral palsy and language delay, so it was a child who had difficulty communicating and difficulty going around, this 55% thought it was severe. So this is also a problem. When we say your kid may have a severe impairment, adults of children and children who were preemies and have this condition, the majority of them don't think it's severe. So then we asked parents about the health of their premature baby. So these were open-ended questions. We didn't have 1,000 parents because it's way too complicated to have tons of pages to read. The impact of prematurity in their lives, their need for information, and their decisional regrets. And for this, if you nowadays in 2025 ask people about their opinion, you need to be flexible. Young parents who are 25, they don't give you their opinion in person while being videotaped and Kleenex. They'd rather text their opinion, make a video. And some parents would rather actually speak to somebody, generally women who have money, and the statistics of who wants to speak to a person. So it's important if you want, we had 98% response rate for speaking to families at follow-up. But because we told them, how can we speak to you? On the phone, on text, on email, with a paper. Nobody wants the paper anymore. Speak to a person. Speak to a person on Zoom. We had 8 ways. We so want your voice. Please tell us, how can you give me your voice. So we had so much text to read. This is what the beauty of my research is sometimes I'm in my office laughing or crying and people are like, no, she's doing her research. So there's a lot of things I learned from reading parent stories for like answering all these questions. So these are the kind of things, answers that you have. And we were 10 people analyzing those answers. For those who don't do mixed research here, we actually decide on what the themes we see in those answers. And then we code the question. So we do it in 2 people. One parent codes the question, one parent participant in that research, not a parent we ask questions. So Rebecca was our resource parents. So she codes the question, a clinician or a student or one of the other 10 people codes the question. And then we look if we put it in the right theme that we had decided to make sure that we're coding it properly. So the perspectives of parents and families were not associated with disabilities. The themes the parents invoked weren't related to how the child was classified as disabled or not. Parents evaluated the health of their child. This is at follow-up at 18 months, and a median of 9 on 10 at 18 months. And we asked them, what do you wish you could improve? And this actually tells you what the real problem is. A lot of them, it was neurodevelopmental, but also a lot of them was important outcomes that we don't measure, such as breathing outcomes, feeding outcomes, sleeping outcomes, medical fragility, being rehospitalized all the time, and behavior, those things that we don't measure. Then we asked parents to choose a statement that best fits their situation. Did prematurity only have positive impacts on your life, only negative, or both? You can see that the majority said both. For the negative impacts, there's so many studies, like this has been over-studied. So PTSD, depression, all those kind of things that you can read. The fear of losing our babies, their hypervigilance that had persisted since we left the hospital. All things that there's a lot of medical literature out there already. So in the negative impacts, there was stress, anxiety, loss of family balance, the child's development, and the vulnerable child who's always sick. We're the first people who actually describe positive impacts about something that happened. They call it in the US literature post-traumatic growth, but for some parents it wasn't trauma and it wasn't growth. You kind of get destroyed and reconstruct yourself, which is not a growth, it's a kind of, redesign more than a growth. So we call it a post-traumatic transformation. So what was the positive impact after going through that crap? Like, it's very weird to imagine. This was described in the cancer literature, in the spinal cord literature, the outlook on life and the perspective. So what's important, what's not important in your life, the importance you give to money or success, or what is excellence, the gratitude you feel for being alive and having all your family healthy and really feeling this happiness that you didn't feel before. The stronger family connection, like who's a backbencher and who's important and who shows up, and to actually show up and say, well, I'll work less, but I'll show up for others in my clan. And the child as a gift. So there's a lot of good example of these parents that they changed careers, that they decided to do something else, or that they're just overall more happy. Then we asked them, knowing what you do know now, what do you wish doctors would have told you about prematurity before or after your child's birth? Like, what are the things that maybe we didn't do correctly? So we had many parents say, well, all the parents answered. You can see that some have so many exclamation marks. This was texted. They didn't say it. It's not something that was transcribed with an interview. So knowing what you know now, half of the parents said, well, we were satisfied with the information you gave us. A lot of parents, 21%, said we want practical information about function and way less diagnoses, like BPD is not important. But what does it mean to have a baby at home with an oxygen tube when you have a dog that will come and trip through it? What to expect for the baby's future, how much appointments, what kind of follow-up? and practical considerations such as the example of home oxygen. Parents really spoke about functions. They don't care about our three-letter words. They want more practical information in the NICU, know about their parental role, what they can do, the trajectory of the baby, the ways to prevent complications. For example, if they read to their child, they sing to their child, they hold their child, and more optimism from doctors. So they say, we are there. We always say, this is a problem, this is a problem, this is a problem today, this is what we're going to try fixing, without saying, this is going well today, we're very happy, your kid's gut is going well, even if there's challenges with the lungs, for example. Then we asked about regrets. It's hard to ask people, do you have regrets? Because then they feel judged. So the way to ask it is, knowing what you know now, is there anything you would have done differently? And we had a lot of interesting answers. The majority, 55%, said nothing. I did what I could or what I was told to do. And the top regret was self-care. Parents didn't take care of themselves. When they got home, they had no batteries left, and it was very difficult. They had accumulated lack of sleep. What was hard to read is 1 out of 6, it's not 1 out of 6 parents, it's 1 out of 3 mothers felt guilt about preterm birth. They were convinced it was their fault. Like, I regret being that nasty person who delivered earlier. I should have done this. I should have done that. I shouldn't have gone to the gym, or things like that. And for some reason, they didn't understand that it wasn't their fault. No parent reports regretting life and death decisions. What was interesting is the breathing important outcomes. We actually didn't ask what are breathing important outcomes. We, through their text of what was hard, of what they wish to improve, of the negative impacts, about half the parents spoke about pulmonary important outcomes or breathing important outcomes. Parents don't care about BPD. None of them mentioned BPD. We didn't say BPC, that word, in 1,000 pages that we read. And all the things parents care about are not measured in trials. These are things, so we do a trial about BPD, death or BPD, even worse, conflating outcomes. So we look at that outcome that parents don't care about, but all the other outcomes are not looked at. People, Brent Manley, some of the BPD researchers, Steve Adman is starting to get out and actually look at those problems. So hospital readmissions, frequent infections, ENT surgery, ENT problems, work of breathing, feeding, nutritional, limitation of activity. So a lot of important stuff, not measured. So that's a problem. So the key message, so I won't tell you this is a big desolation, I'll tell you what we can do about it. But the key message from the voice of parents is that the NDI classification we use doesn't correspond to the lived experience of parents. It's more pessimistic, and it actually misses the point. Parents generally have a positive perception of their child. They also have negative impacts. For parents, function that we don't really measure is more important than diagnosis, and there's many important things that are not measured. So what can we do in research? We can measure these outcomes. And it's actually complex to do that. The first mistakes that neonatologists or doctors do, but especially neonatologists, is they validate medical important outcomes. So if you read the core outcomes paper, neonatologists get together and they say, oh, okay, Mom Tremblay, tell me which is most important in that list of bad things that can happen. ROP, BPD, NDI, blah, 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 IVH type 3, IVH type 4. So the parent ranks what is important to us in a different way. And BPD for parents then is not important because they're like, what is that? Like, it's IVH seems more important. So validate, instead of going bottom up and asking parents what's important and looking at what we could measure, we do it the other way. Seeking a consensus, the Delphi method. Parents are all different, so there won't necessarily be a consensus. And doing the research without parents for real, just having somebody on the board to get the money, but not integrating them in research. So I'll take the BPD example again. If you don't integrate data that's important to parents, there's harm of actually measuring BPD because it may not correlate with long-term functional breathing outcomes that are important for families. So if, for example, all the trials for steroids to reduce BPD those that have looked at lung function and about readmission and things like that, they are not correlated with long-term lung function. And some trials, like the COIN trial, reporting no impact of BPD, actually report better lung function and less readmissions. So it's possible that we give steroids, the little bronchial tree doesn't grow that much, but there's less inflammation, so less oxygen, but the little bronchial tree that doesn't grow that much, that has a lot of negative impacts in the future. So not measuring what's important leads to positive or negative results that are probably not important to families. So where are we going research-wise? In the Canadian Neonatal Network, we call it significant, not severe disability. And we're trying to redefine outcomes, but it's very hard because the whole world works with those outcomes. And there's new measures that we're integrating that measure function. So this is a scoping review of all the ways you can measure parent-important outcomes. It's part of the Voice of Parents big initiative. So I'll give you an example of what is important to family and themes and how we can measure it scientifically and rigorously. So there's the well-being of the child, the quality of life of the child, functional outcomes, for example, if the child can move, function in society, socio-emotional behavior, breathing, the Liverpool questionnaire is great for that, feeding, sleeping, and caregiver mental health, the parent's mental health. That has a direct impact on the kid and vice versa. So these are all functional questionnaires that can be used in clinical trials and in neonatal follow-up. So we've started to put the About My Baby in PCHGR for all the kids in Canada at 18 months. The next one would probably be the Liverpool questionnaire. We're working on a breathing important outcome PREM study with one of the big machines of developing trials, Brett Manley, who's in Melbourne, Australia, with CHOP, Catherine Callahan. And the goal is we interview parents when they leave the NICU and later on about all that list that we spoke about of pulmonary important outcomes to know which is most severe than which. For example, is it worse to go home on oxygen for 6 months or to stay hospitalized a month extra? So what is the ponderation and what is worse than what in terms of quantity? And to be able to have actually a score. So you'll have a breathing score at 18 months as opposed to BPD or no BPD or whatever, to be able to see if an intervention works. Another new method that integrates parent important outcomes is the desirability of outcome ranking. So all of you, the young ones with no gray hair, you'll see that a lot in the future of medicine. It's actually really used in cancer a lot right now for adults. So the way we do research in neonatology, we're kind of always 1 to 2 decades behind to integrate stakeholder outcomes. And for cancer, they're kind of always a little bit further up for all the questions about like mastectomies and colectomies and prostatectomies of what people value and what to actually do and how to present these options. So the DOOR analysis is a multi-criteria approach that allows researchers to rank outcomes based on what is important to parents and to do trials to see what is the good outcome. And it's actually rigorous measures. It's not just the parents happy. So I'll give you an example. And Anup Katharia is really a leading figure in that. He's in San Diego in this. So Anup's done a study of cord clamping, umbilical cord clamping. I'll show you the other slide and I'll go back. So it's the cord clamping, and then he's done the study of cord milking. So this study was the cord milking for non-vigorous infants. The findings were published. It was found out to be non-significant to favor cord milking for cord clamping. Then he asked his parents what was important. He redid that study and found out actually cord milking gave out much better results. And it favored the babies that had cord milking. So how did he do this? So when you have a non-vigorous baby and you do cord milking, a number of things can happen. You can receive PPV. This is not a big deal. So parents judge that as bad, but not as bad as an ICU admission. to have a CPAP. That's bad, but not as bad as having mild HIE. That's bad, but not as bad as having moderate to severe HIV. That's not as bad as being dead. So these have different scores. And if you actually integrate those scores in the randomized trial, it favors cord milking. So I think we'll have more and more of these studies. In the cancer literature, there's no study with death or colostomy. We do these studies all the time in neonatology. It's kind of a joke now, death or BPD. To me, it's such bad research, or it's something you don't see anywhere else. So, but we're moving out of this. So what can you do clinically for those who are not trialists in the room? Well, you have to be aware of parent-important outcomes. The first one is, it seems very simple, is to know, for the parents to know who you are and why you're there, and not to just go in the room and get out, and to know the name of the baby and to use it. So they don't know what a GI fellow is. They're like, GI Joe, what the hell, what is this? And what's a fellow? He's a friend. What's an RT? Like we use these words. It's this little special society that a lot of people are not aware that exists. For neonatologists, sometimes they think it's a religion. Like if you really don't explain, I'm a baby doctor, people may not know this. And it looks very simplistic, but people don't. Do you round sitting down? And please don't round all standing up behind computers. This is the worst thing you can do for parents. They won't tell you what's important to them. If you're all towering up and coming 10 people, I wouldn't do that. Like my friends don't do that to me. We sit down, and even with my friends, it's hard to speak about my emotions. So if it's a group of people who are standing up with computers, this won't happen. How to address the guilt? I say this every day. Like as a parent, we often think these are all quotes that parents said were very important to them, were the best thing they heard in neonatology. As a parent, we often think what we could have done better. You have to know there's nothing you could have done to prevent what has happened to your baby. So I use this for prematurity. When a baby has neck for the milk that was used, when a baby has an infection, it's not something they gave them. When, I don't say that if they actually injected cocaine and had a placental detachment. But generally in neonatology, parents didn't, it's not because of something they did that something happens to their baby. Personalizing information. Some parents, other parents, if you remember that for medicine, you're all set. Like some parents want a lot of information and statistics. Other parents just want the big picture. What kind of parent are you? Or some parents want to decide life and death decisions. Some want recommendations. Some in between. What kind of parent are you? Some want to know how the respirator works. Some don't. Some want to be around. Some don't want to be around. Some want to speak on the phone. Some want to see on the phone. So you can do, instead of saying, do you want information? What kind of parent says no? They'll say yes, they won't listen. And then the next day, nurses will say, oh, I don't know. Or doctors will say they don't listen, they don't remember, they're in shock. No, they don't give a shit to what the respirator does. So this is how my garage person speaks to me. Do you want to know what I'll do? No. My accountant, do you know what? No, just do my stuff. Don't explain to me what's going on. And some families don't really want to know. They want just to know is it going well for a 26-weeker? So parents want practical information, how they can prepare to be the parents of a sick child, how the unit works. This is true everywhere in medicine, and what parents can do to help. We have prenatal workshops after the prenatal consults where they visit, they see where the kitchen is, how the breast pump works, how they prepare to be parents in neonatology. We want to know what our children may not be able to do, but also what will they be able to do? Well, how are other families doing? Can you give us example of the worst case scenario, not severe disability? What does it mean? We want doctors to be realistic, but also optimistic. And we want to know that we can adapt and cope, that we're stronger than we think, and that parents also report positive transformation. And we need information about function more than diagnosis. So how can we do this practically? We called it the Hope Wall, le Mur de l'Espoir. So if you go Saint-Justin, Mur de l'Espoir, you will see tons of stories with videos of parents and what recommendation they give to other parents. Some of them had a kid who died. We don't have all like miracle babies that climb the Kilimanjaro. It's all real stories. There are surgeries. There are twins that some of them died or not. if we're all from the US, you have the Courageous Parent Network. That's absolutely amazing. If you go in there, there's tons of videos about tons of leukodystrophies and all the rare things you will see parents give advice to other parents. So this is a really great place to go. Peer-to-peer support can help. Educational workshops work really well. So every Wednesday we have an old parent, or you call them veteran parents. So resource parents come to the NICU and speak to the new parent about what it is to be a parent. We've got one with a social worker to like optimize money and organization. One about breastfeeding. We get all the parents together and like joke with the pump. And at Halloween, all the breast pumps were made up for Halloween with hats and stuff. So we have like funny things happening. Developmental care workshops, discharge, my baby's lungs. And we have every week to instill a bit of optimism in our pessimistic culture in neonatology. We actually have something that works out well. So I don't no longer have caffeine. My grandma, sometimes there's nothing much that's better for a baby. So my grandma just came from France. It was just Halloween. It's my first Halloween. And I think most importantly, I think probably residents will have heard about the F words. It's getting more and more developed outside again of neonatology and the rehab literature with the WHO ICF framework. So to speak about function and not diagnoses, so the way we would go is we would say, oh, your kid may have a severe disability. He may be deaf. He didn't pass his hearing test. So how can you use the F words? There's videos. If you go on the F words, you have free workshops, you have videos, you have explanatory things, and it's now in pediatrics exams, at least in Canada. And if you want to invite a person, invite Peter Rosenbaum. He's very good at speaking about this. So it's function. So your child may be deaf, but she will be able to function in the world. We know that kids that are deaf have friends. We know that it's hard for their family. They have to come often to appointments, the cochlear implant, how it works. It's not something that's easy, it's a surgery, but it enables the family to communicate. We know that these kids can have fun. They can be fit. Outside of having a cochlear implant, they can do a lot of sports. Then they can have a future. Like these kids can connect with a cochlear implant to a lot of things, to the TV or house, to the Zoom. So this is how to speak about a disability as opposed to just your kid maybe have a severe disability and be deaf. And you can do this with cerebral palsy. You can do this with all the severe outcomes. So in conclusion, redefining outcomes and classification of outcomes in neonatology is essential. Severe categories are just the values of the doctors, and they should no longer exist. It's very important that we try to decrease cerebral palsy. We need to measure it, but we don't need to call it severe. The description of outcomes, so for example, non-ambulant CP or deafness that will need to use a cochlear implant is more appropriate. Function will be measured in future trials, not only diagnoses, especially in the BPD literature. Those who just study BPD are just for nothing is significant anymore. Everything's been tried. So a lot of BPD researchers are tuning into this to say, hey, maybe we'll have positive outcomes. So family important outcomes will be integrated in clinical trials. And it's being measured now for congenital heart disease and HIE. So we'll have more data in the future. And research methodology is developing quickly. So there's many fellows at our hospital. Quebec is nice, but there's a lot more snow than here. So we welcome people who speak French every year, if there's one of you in there. And if you have questions, you can write me if you want the papers. You can write me if you want to buy my book. It's on PDF. It's easy to find. So there's a couple of questions for a couple of minutes for questions. Yes, I think it needs to be green for people to hear us. I'm used to repeating questions, but apparently here you're sophisticated.
So my name is Wendy Bernatovich, and I practice clinical complex care and palliative medicine. And I'm curious, in your research, if you spent any time talking to families who decided not to resuscitate, and then out of the families who did resuscitate in the ICU, who sort of eventually, maybe in 2 or 3 months when things weren't going well and they felt like there was more harm than good, and they sort of withdrew or allowed a natural progress. I'm so curious about how those families made those decisions and why. And so I don't know if that was part of your research at all.
That's part of my first 10-year bolus of research. That was what I was supposed to speak about. So I'll speak about that with the fellows. It's a whole different presentation.
Yeah.
This was on those who survive what's hard and not, and how to take these decisions and how to speak to parents and how to, in short, like some parents, other parents, many parents don't want to decide. Shared decision making has done a lot of harm. Parents often want recommendations. And yeah, that's like, I'm trying to summarize. And CPR, writing DNR orders that parents sign is a very bad thing to, it actually sets you up for failure. All these, the system, I think, that exists around that. But you can send her my presentation, or you can come to the fellows presentation.
Yes.
I guess. Sorry.
Thank you.
So, I mean, we all kind of know with research output, you want to get stuff out there quick. And so I think that's probably one of the reasons the 18 to 24 months became our standard of care. You could get a study done in 5 years. Yeah. There's 2 questions to this. How do we motivate researchers to wait the 8 to 10 years? I mean, it makes sense why HEMONC comes out faster, because their outcomes are probably 1 to 2 years because these are adults, right? We need to wait 8 to 10 years to see how they're doing in school, their ENT. How do we get researchers to like have the incentive to do research and wait those 10 years to get those outcomes? And B, would you suggest not even publishing the 18 to 24 months? Because once it's out there, it's biased in our mind. And we know they don't correlate at all. So if you're going to do a longitudinal thing, would it be best just to not even do the 18 to 20, just wait to 10 years, or, you know?
Well, there's some things that are important for like CP. You don't want, even if the kid can walk unassisted, it's not something we want. So I think some diagnoses are important. I think all the BPD research with 36 weeks oxygen is bogus, to be honest. But I think if you look at what's important to families, you can see that tracheal reconstruction is associated with number of intubations that we don't measure. You can see that number of rehospitalizations seems to be linked to nutritional outcomes, growth, steroids. So these links have not yet been done because we don't measure those things. So if we measured ENT surgeries, if we did a study to really take a cohort and measure it longer, so there's some adult cohorts, but the failure to follow up is very tough. But if we have, when we'll have the breathing important outcomes, like what Brett Manley wants to know is, how does it correlate to what happened in the NICU? And if we know what it correlates to, then we can push the nutritional stuff. We don't care if the kid has oxygen at 36 weeks, but we will try to not use, for example, steroids as much and blah, blah, blah. And maybe we'll, so in the first 18 months, there's a lot of things we can measure. We can measure readmissions. We can measure a lot of stuff that the parents have said is important. Feeding outcomes, we don't measure, it's not even measured. It's not part of the NICHGR, any kind of neonatal follow-up network. And this can be measured at 1.5 years easily, and we don't do it. So there's a lot of things that we can measure quick, and there's a lot of long-term things that we can see how they correlate to the NICU that we don't do yet. But it's starting slowly to happen.
Thank you. We need to end at 8:30, so that's what. Thank you.